Good afternoon, and welcome to Insight Memory Care's Care Partner Training, Trauma-Informed Care in Dementia. Our mission is to provide specialized care, support, and education for individuals in all stages of memory or cognitive impairment, their partners, and the community. Our vision, a community where those living with memory or cognitive impairment and their care partners can achieve the highest quality of life. We're a leader in dementia care in Northern Virginia. Insight is a nonprofit started in 1984, supporting families in their dementia journey. And we are happy to say that we're having our 40th anniversary next week. We provide care that is specialized adult day programs for people in all stages of their dementia journey. We connect by building relationships and supporting care partners on their journey, and the creativity of our dementia experts sharing their knowledge and resources, because every journey is unique. I am Melissa Long, the Director of Education and Support. A few housekeeping tools. We have a Q&A. Please feel free to put your questions in there, and we will get to them at the end. But I would like to introduce Chrissy Cunningham, the Prevention Coordinator Specialist for Fairfax County. She's going to talk about trauma-informed care dementia. Welcome.
There we go.
It is presenting the presenter slides on Zoom. Just FYI.
Okay. I'm not sure how to get rid of that.
Do you have any notes underneath any of this? There's no notes, so don't worry about it.
But can people see the whole slide okay?
I think so. She's not able to flip it to the full thing. If you guys can't see, if someone can throw in chat that we need to figure it out, that's fine. If not, we'll just go ahead this way.
Stop and try again. Right, don't work on Zoom too.
There you go. You got it.
Is it working?
Yeah, you got it.
Oh, okay. Well, there we go. Never be able to replicate that. Well, thanks for having me. I will jump right in with a definition of trauma. And this definition comes to us from federal government, from the Substance Abuse and Mental Health Services Administration. And I remember it by thinking of the 3 E's. So trauma is an event, series of events, set of circumstances that is experienced by the individual in such a way that there are lasting effects. So event, experience, effects. Most important E is experience. Folks could be exposed to the very same event or set of circumstances, and everyone's experience of that is going to be different. Great example for current times is COVID. We have all been exposed to the same set of circumstances. We have all survived a global pandemic. But our individual experiences of that event are going to look very different depending on our health status, our income, other things that we may have experienced in our past. Did we get sick? All kinds of different things are going to inform our individual experience of that event and whether or not we may have lasting effects as a result of it. Important to keep in mind as we kind of continue through our conversation about what trauma is and different types of trauma that folks might face, just as far as trying to avoid making assumptions. Just because you know that someone has been exposed to certain types of events in their lifetime, we can't assume that they have lasting negative effects. One more kind of definition to help set the stage here. Trauma-informed care. There are the 3 E's for what is trauma. There are 4 R's for what is trauma-informed care, or what is a trauma-focused approach. First and foremost, it just means that we realize that trauma is really common in our population, and for our purposes today, that it absolutely impacts older adults. The second R, that we recognize the signs and symptoms when we see them. And we're going to talk about what some of those signs and symptoms might look like in the older adult population. Third R, we want to actually take what we know and respond. We want to take actions that are going to make people feel safe, physically, emotionally, and psychologically in response to what we know about how common this is across our population. And lastly, we want to not re-traumatize people. There are certainly things that all human beings can face in all settings that can be stressful and triggering and can bring up memories of past traumas. So we want to make sure that we're not doing that. So what do those symptoms maybe look like? These are the lasting effects when we think about that trauma definition. We can see things like intrusive thoughts, distressing recollections of things that folks have experienced in the past. And intrusive is really the key word there. I think, everybody has experienced stressful things in their past that they may think about or reflect on from time to time. But when we are thinking about a trauma, we're really thinking about those intrusive thoughts. They are getting in the way of people's daily functioning, and they are troubling. We can see that when folks are asleep, those reoccurrent distressing dreams that can ultimately impact folks' ability to get the sleep that they need, which can show up as irritability as a result of that sleep disturbance that folks may be facing. People can experience flashbacks. Sometimes we will know that a flashback is happening, and sometimes someone may be behaving in a way that seems really odd for the moment, and we may not even realize that they are experiencing a flashback. But the flashback is really when someone is re-experiencing a stressful or traumatic event, just like it's occurring in the present moment, even when it's not. Triggers is a word that I think a lot of people are familiar with at this point. Folks who've experienced trauma can experience distress when they are exposed to triggers. And there, unfortunately, are a lot of different things that can be triggers. They're often hard to predict. They can be difficult to recognize. Part of our work, hopefully with everyone that we're serving, is thinking about what might be triggering them and trying to identify them whenever possible so we can think about how to not re-traumatize. An example that I often give about kind of how these might not be easy to figure out, like maybe somebody is in a car accident at night, and as a result, they say, okay, I'm not driving at night anymore. I'm not riding in cars at night anymore. That's like a really obvious, logical, okay, this is a thing that happened, and now this person is afraid of being in that situation again. Often it's not that simple. It could be the sound of somebody's voice. It could be the weather at a certain time of year. It could be a song on the radio. It could be furniture in a space reminding them of furniture in another space. So many different things that may not even be consciously recognized by the person who is triggered by them. So just want to highlight that is, not always an easy thing to figure out exactly what is triggering folks. But people do have and can have very intense reactions when they are reminded of the traumatic experiences that they've had. And that can show up as people avoiding certain activities, certain places, certain people, anything that kind of reminds them of that trauma, because they have, kind of really subscribed to negative beliefs and expectations about those people, places, situations, environments, etc. Some other examples of triggers and things that you might see when folks have traumatic memories, certainly around like dates, the loss of a loved one, the date or anniversary of a serious health crisis, where maybe they lost mobility or some sort of freedom or capacity for independence. Certainly being in any kind of care setting where there is structure such as that they are not maybe making all their own decisions to do all the things they want to do when they want to do them, could be a reminder of, like, for example, with the older population, maybe being in a prison camp during the war, something like that. Really kind of any time that folks don't have power and control over what is happening to them, I think is an easy way to think about this. No matter what the type of trauma somebody experienced, whether that was, being in the war, losing a loved one, being abused, they didn't have power and control over the situation. So anytime somebody feels like they don't have power and control over the situation, that can be triggering, even if it's a totally different kind of situation than their trauma. Just that feeling of, I don't have power, I don't have control, I don't have a say over what I do and when I do it, can be triggering. Noises, I mentioned, like the radio. I've heard examples of like cleaning products that maybe folks were around in certain environments, and then later on they smell them again, and maybe they don't even realize. But it's very much like a biological response that all humans have when they are reminded of things that were traumatic. So thinking about kind of specifically older adults, certainly things that occur in everyday life for someone of any age could remind them of traumas that they experienced in the past and could kind of activate that stress response. We often are not going to know whether or not somebody has experienced a trauma. But what we do know is that exposure to trauma in our population is very, very common. Like at least 60% of the population has experienced at least one traumatic event. I think the number for older adults is like 90%. They've been with us longer. They have much more life to have experienced different traumatic events. So we know it's really common. We don't always know the details. We don't always know the story, but kind of taking the stance that we just assume that everyone has experienced something is very trauma informed. We really want to be able to acknowledge we're taking a trauma informed approach that past and present events have been traumatic for folks. We want to accept that, and we want to figure out what strategies we can use to make them feel safe, and to make sure that they're not feeling traumatized by their interaction with us and with the setting that they're in. And if we get information, like specifics, like somebody does share or disclose that they've had a particular type of trauma, we do want to share that with the care team. The more people are aware of what folks have experienced and what their triggers might be, the more we can kind of work together to manage potential triggers. Kind of the basic things that we want to do. I've mentioned safety. Safety is a huge thing. When we're trying to be trauma informed, we want the physical space to be safe, but also we want people to feel safe emotionally and psychologically. A big way we can do that is by building trust, right? When people feel like they can trust us, they're going to be more likely to feel safe, right? When people don't feel safe, it very often could be a result of them not trusting caretakers or the folks that are alongside them. The more we can create collaborative relationships, right, that's part of establishing trust. That's part of giving people autonomy and choice. I mentioned that often people are triggered by not feeling like they have power and control in a situation. The more we can offer choices, the more people feel like they have power and control. Even if lunch is served at noon on the dot and people don't want to eat at noon on the dot, being able to choose where they're going to sit, having maybe a couple of choices on the menu, like little things like that can go a long way towards contributing to that autonomy and choice that can help balance out how triggering it might be to not have that kind of power and control over something like the schedule, for example. Strengths perspective. If folks have heard of that before. We want people to feel, ultimately empowered and not kind of unable to cope with any symptoms or triggers that they might be experiencing. Everything we can do to like support people being more resilient, and we're going to talk more about kind of all of this stuff later, can help people learn some new coping skills and ultimately, kind of heal some of those stress responses that may be impacting their functioning.
Could you give an example what a physically safe room is for someone with you said trauma?
Yeah, so certainly it may look different based on the setting or the specific person. Certainly when we're thinking about, older adults, you want to think about all the things like, fall prevention and some of those basics. An example that I will give a lot from my early social work training is that I was trained to sit in the room when I was like one-on-one with a client where I would have my back to the door. So if that client started demonstrating aggressive behavior or something like that, I could make a quick exit out the door. Well, what we know now is that that's really not maybe great for someone who's experienced trauma, because my back's to the door. That means that their back is probably to the wall or the corner, and to go through the door, they have to go through me. So how do we arrange the furniture where like everybody can see the exit and get out of the room if they need to get out of the room? A lot of times spaces will be set up such that, people are entering from behind and folks are, facing away from entrances and exits. And that can certainly make some people feel triggered, that they don't know who's coming, they don't know who's going. So thinking about furniture arrangement like that, certainly what kind of like artwork you have on the wall, whether you're thinking about like different, like diverse, racial and ethnic groups, LGBTQ populations, having, posters and artwork and signage that is inclusive can make people feel like safe and accepted, some things like that. Okay, so I touched on this a little bit already, but just kind of thinking about that fourth R a little bit more, avoiding re-traumatizing folks. If we get information that someone has experienced trauma, we definitely want to talk about that with the care team. Think about how can we prevent triggers. Let's try to predict what some triggers might be. Let's come up with a plan. Understanding kind of if folks are having intrusive thoughts, if they're having nightmares, if they're having sleep disturbances, all of those things can be helpful in coming up with a plan to support the individual. Universal precautions is something that we talk about in the trauma-informed space. If anybody's ever had like bloodborne pathogens training, that, if someone slices their leg, that we don't sit down next to them and ask if they've been exposed to HIV or hepatitis in the last 30 days. We just assume that they have a bloodborne pathogen, and we always wear gloves when we administer first aid. Same kind of thing with trauma. We know that trauma is so common in our population that if we take this kind of universal precautions approach and just assume that everyone's been exposed, number one, that takes us off the hook for feeling like we have to like figure out exactly what everybody's been exposed to. But it also really helps us like think about and prioritize safety. And there's nothing that we're going to do to help folks that have been impacted by trauma that's going to hurt folks that haven't been impacted by trauma. Everything that we would want to do to support folks that have experienced trauma is going to be stuff that's going to be helpful to everyone that's in the space. So shifting gears a little bit, talk about the brain. So trauma impacts the brain. Those lasting effects that folks have after they experience trauma is because our brains are impacted by all experiences that we have. And when we have experiences where we don't have power and control, where our safety is compromised, that result in those lasting effects, there are changes to our brain. There's lots of brain images you can look at on the internet if that's your thing, and see how the shape and size and structure of brains looks different in folks that have had a lot of exposure to trauma. The good news is that our brains continue to grow and change until the day that we die. We can lay down new neural pathways throughout our life course. There's certainly much more brain development happening in early childhood and adolescence than there is later in life, but we can learn some new skills. We can learn some new ways of adapting. But when we look at behaviors and we look at the responses that folks have to trauma that may be challenging for us to deal with, it is really important to remember that, really there's no such thing as maladaptive behavior. All behavior is adaptive because all brains adapt to experience. So if someone's experience has been trauma, their brain has adapted to that, and the strategies that they use to feel safe and survive and function, while they may be problematic to those around them in some cases, those are adaptations that their brain has made to help them keep moving forward. All behavior is adaptive. Behavior is serving a purpose for the person who is exhibiting it. Behavior has a function, right? All behavior is communication. We talk about that when, we're dealing with really little kids, even in preschool. Behavior is communication. Folks might be trying to have sensory needs met, attention needs met, all kinds of different reasons that folks may be acting in the ways that they're acting. Just remembering that behavior is communication and it's serving a purpose, and that trauma is really common, can kind of help us take a more empathetic approach to those challenging behaviors. And ultimately, we want to take advantage of any and every opportunity that we have to teach new coping skills. Certainly, I said there's no such thing as maladaptive behavior. It's probably a tougher sell to say there are no negative coping skills. There are certainly coping skills that are not healthy. Substance abuse comes to mind, of course. Still may be adaptive for the person who is struggling with that. So anytime we can give the brain exposure to new experiences in the way of either modeling or directly teaching or instructing on healthy coping skills, the more we are going to be, supporting that person and hopefully adopting some behaviors that are not going to be as problematic for those that are trying to work with them. Exercise, deep breathing, meditation, kind of creative pursuits, coloring, painting is helpful for a lot of folks. Even just like getting outside, listening to music, any kind of movement, lots of really simple things that can be helpful, and that folks may have just not been exposed to or may not have tried. And when we're thinking about, folks that have experienced a lot of trauma, they may need a lot of repetition and a lot of exposure to new coping skills until they find things that work for them. We can help people build new skills in whatever environment they're in until the day that they die. Little caveat here for, if we're dealing with folks that have dementia, obviously that is a much harder thing to do. Teaching coping skills, more difficult in those circumstances. Exposing people to those calming, soothing things that I just talked about, the movement, the deep breathing, the nature, all of those things can still be helpful. A little bit of a different, situation though, as far as expecting people to adopt a new skill and, use it in the future. They'll need kind of that constant support. But the example we have here is that, someone with dementia could be reassured, taken away from what is triggering them, if we can figure out what that is. Sometimes just a change of environment. We can't figure out what's triggering them, but having a quiet space, a sensory room is a great option always. Offering them the opportunity to talk about it, or offering them, to the opportunity to take a walk with someone, giving them some different choices. Really important to have a space where folks can go. If folks get triggered and folks are acting out, particularly in a group environment, that can then be triggering to other people in the group environment. And we don't want to be in situations where we haven't kind of thought through Where can we go? What's the plan B? You know, is it the car? Is it a walk around the block? Is it a special identified sensory room? Kind of where can we take people if we need a change of scenery? That could be soothing. I'm gonna talk a little bit about kind of what folks may share about their traumatic pasts. You may be in situations where you are kind of asking people, and I love the example question that we have here, where you're just kind of saying, some people have shared difficult experiences with me. Has anything like that ever happened to you? We're not going down a list and, has this ever happened to you? Has this ever happened to you? Has this ever happened to you? But we're normalizing right up front, right? Like a lot of people that we work with here have shared this kind of thing with me. Has anything like that ever happened to you? So right away, it's like, okay, this isn't maybe just something that I've experienced. Maybe this is common. Maybe this person can handle this information if I share it with them. If people do share things with you, how you react is really important. If somebody discloses something and we have this like dramatic face and oh my gosh, that is like the worst thing I've ever heard in my life, and I don't know how you survived that, and like you're crying and you're very kind of like emotionally responsive to what they shared, they may think, oh, this is why I don't tell people this. Now she's upset and other people can't handle this information. So we want to be like as neutral, calm and stable and just compassionate as possible. We can say that we care, we can show our concern, but with that like stable, neutral, calming presence. Like, I'm sorry this happened to you. That must have been really scary. I know this has happened to others. You're not alone. Like whatever we can say to kind of like validate their experience, normalize that this is not the first time we've heard something like this. We don't want to question, like, did it happen? Is that true? Are you sure about that? And we don't want to probe for details usually. There are certain people who are in roles, adult protective services, child protective services, the police, where they are, in a role where they are asking people for details and names and dates and all the gory details of situations. Most of us are not in positions where we need to do that, and nor should we do that if we're not in that kind of a position. We don't need details. We just need to encourage, support, validate, normalize, and then be thinking about, okay, what might some triggers be? How do we establish safety? And again, if we are doing those kind of best practices of making sure that people feel safe and giving voice and choice and trying to empower folks and support their autonomy, if they disclose, trauma, we're already doing a lot of the things that we need to be doing to support them if we take that approach from the beginning. So we're going to kind of close out our presentation here by talking about some techniques that can be used to treat trauma in older adults. Folks have probably heard of psychological first aid and psychological recovery. Kind of the gold standard kind of counseling intervention is cognitive behavior therapy, and there are even some specific variations of that are trauma-focused cognitive behavior therapy, and then exposure therapy. Eye movement desensitization and reprocessing, or EMDR, is, there's a whole slide about it. I'll talk about it in a minute, but a kind of more active intervention that's also done in like a counseling setting. Both cognitive behavior therapy and exposure therapies will have some element of having folks kind of review their experiences and kind of develop a narrative or a story around what has happened to them. So psychological first aid, and this is like all going to bring you back to hopefully what we talked about with universal precautions. It's a lot like medical first aid. You don't have to be a clinician. You don't have to be a social worker or a psychologist or psychiatrist to use psychological first aid. It's really about reducing the initial stress. caused by traumatic events. So if something is happening like presently, if there is a loss or a trauma or something that somebody is dealing with, that isn't something that happened 10 or 20 years ago, it's something that's happening right now, we can kind of immediately come in and be supportive, offer safety, offer water, offer a snack, offer a listening ear, kind of all of those things in the moment. A lot of what we're learning about trauma is that kind of how people are supported and responded to immediately in the aftermath of a traumatic event can have a really big impact on how lasting those effects are. So if we respond appropriately with psychological first aid, we can, have an impact on whether or not their functioning is going to be ultimately impacted to a high degree or not. Psychological recovery. This is where we like sharing information about normal reactions to crisis. And it is back to that kind of validate and normalize, right? Like it makes sense that you're distressed right now. It is really common for folks to have this kind of a response to the situation that you're experiencing. We provide education around stress and coping. Your heart rate's elevated, your blood pressure's up, like you're clammy or you're sweating, like help people recognize all of those like physiological symptoms that they're having for stress, and then like actually actively talk through what are some things that we can do to help kind of calm your nervous system response. What are some things we can do to restore your sense of control? Encourage them and help facilitate connection to folks in their network that can support them formally and informally. Very similar to psychological first aid is like in the immediate aftermath of something happening, really trying to work with folks to validate and normalize and educate and introduce some coping skills, connect them to resources right away. Would be really helpful. Trauma-focused cognitive behavior therapy, or TFCBT, as clinicians refer to it, is like a 3-phase kind of evidence-based treatment where folks can expect to be in treatment for like 6 to 20 weeks. There's family component when appropriate, which is in most situations, where folks are, first kind of going to be identifying those like intrusive thoughts that they may have as a result of the trauma, whether that's like the memories of the trauma, whether that is kind of negative thoughts they have about themselves or their functioning as a result of the trauma. And then they're going to evaluate whether or not these thoughts are valid or maybe they need to be challenged. And this is kind of the basis of all cognitive behavior therapy. Is that we then want to take the thoughts that maybe don't make sense and should be challenged and replace them with more helpful thoughts. The trauma focus layer of this is we're doing all of this kind of in the journey to write a trauma narrative, or record a trauma narrative in some way. There is quite a bit of evidence that when folks can kind of take their experiences and package them in a way where they have like made some meaning and sense of them, like this is what happened to me, it wasn't my fault, this is how it impacted me, these are maybe some positive things that I gained from it, I wouldn't have met this person, I wouldn't have gone to this place, this is how I'm going to move forward, just kind of like putting it in a box can be helpful for folks. So that is a big piece of the TFCBT, is coming up with that trauma narrative and kind of walking out with that at the conclusion of treatment. Can include some, I don't know what just happened to my screen.
Is your battery done?
Maybe. I have a bug. Should I grab it right now?
Yeah. One moment, please.
Only been like 1 hour. Battery should last for many hours. And I should get a warning.
Let's see.
I'm so sorry. Wild. 7 horns. Just if you died. I'm so sorry. I can absolutely just keep talking about slides if you want me to.
Go for it.
So I was about to move on to the EMDR slide, I believe. I type and talk at the same time, I know that much. Give me 1 second to get logged back in.
There you go.
Oh, okay. Zoom and do I need to share again?
Yes, please. There you go.
Okay, we're back in business. So an element of TFCBT and then also of movement desensitization and reprocessing, EMDR, is this kind of idea of exposure. So, if it is a certain environment or, situation that is triggering to folks, figuring out ways to kind of re-expose them to those environments in small doses and of increasingly lengthy time over the course of treatment to help them, figure out how to calm their nervous system when they are in these triggering situations. So EMDR, there's a picture on the screen that really is what it looks like. It's fancy stuff, but it is about, activating neural pathways in the brain. There is some movement involved, not just of the eyes, but there could be like some tapping. There's lots of research about kind of bilateral stimulation and how different parts of our brain are activated in response to stress, and how we can kind of do things intentionally to activate different parts of our brain when we are thinking about those stressful situations to, again, kind of help change our thinking about the traumatic event and how we respond to it. So totally different methodology, but still kind of the same goal in terms of helping people think about their experience differently, kind of integrate it into their life story. Just develop kind of a narrative of what it is that occurred. Great website here that has resources for older adults and families. It's great advice about kind of what trauma is, how it affects people, post-traumatic stress disorder, which post-traumatic stress disorder is a DSM diagnosis, like a clinical diagnosis where people have to meet specific criteria in order to be diagnosed with PTSD. We talked about how common trauma is in the population. Only about 6% of people who have been exposed to trauma will meet the diagnostic criteria for PTSD. So PTSD is actually not anywhere near as common as folks who have experienced trauma and are having impacts from it. So super important to think about, because sometimes people hear that statistic about PTSD and think, oh, that's like not that big of a number. But there are many people walking around that are, suffering from, very serious functional impairments and impacts of their traumatic experiences that don't rise to the level of PTSD, who can still, very much be served by us promoting, safety and autonomy and empowerment and all of that stuff that we talked about. Great practical suggestions there. With that, I think we are on officially to questions.
All right. If anyone online has any questions, please put them in the Q&A box and I will gladly ask them. Thank you so much for coming and talking to us about this. We see it a lot with people's reactions when we're doing care. An example, we had someone who had a really hard time on the transportation to get here. And so he now wears headphones and listens to music on the way here and he's calm. So we found something that can help him cope in those moments. And hopefully other people find ways to do that as well. I'm guessing the PowerPoint was very thorough because we're not getting many questions.
We talked very fast.
Okay. All right. So our upcoming events, you can always go to imcc.org/events. Our next care partner presentation next month in August is on the 14th. And we're having the Lewy Body Association talk about managing Lewy body dementia. So feel free to sign up for that. And we want to thank everyone for coming. Might have gotten a question. Trauma response is people with dementia look like what kind of behaviors? So what behaviors do we see with trauma with older adults?
So I mean, really, it could be very similar to what we would see in anyone. Maybe just aggression that seems unwarranted, or like an overreaction to the situation. We could see, there's like two ends of the spectrum, right? There's some folks who are triggered and they lash out, they get emotional, they get loud, they get aggressive. And then kind of the other side of that is, folks may just like check out. They get silent, they kind of withdraw within themselves. It's supposed to be very hard to tease apart if you're someone that has dementia, because that, may be a very normal behavior for them. But it's really that like fight, flight, and freeze response that all human beings would have if they are faced with a stressful situation. When folks have experienced trauma, when they are triggered, that's often where they go back. So fight, flight, or freeze, they're going to fight, they're going to run away, or they're going to freeze, like, playing dead. You see a bear in the woods, some people fight it, some people play dead, some people run away. What does that look like, in a room when someone is triggered? Well, that like playing dead looks like, just like checking out. I'm like off in my own world. I'm not kind of listening to what's going on around me. Obviously that's easier to deal with than the aggression, kind of the acting out that we can see.
I think what we've always had like in the back of our mind as professionals working with older adults with dementia is someone who may have been in the Holocaust and getting baths and showers and dealing with water. And so do we do bed baths with that? Do we not use the shower? Things like that. So I think that's when we're going to see behaviors with care, because it's sensory based, getting too close into their space. If there's someone who had an assault, and getting too close to them, getting in within their hula hoop, as I call it, into their space. And we have to, it comes back down, like she said, to communication of us saying, I'm going to do this, and now I'm going to do this, and now I'm going to do this, with that calm voice, that they know every step that's happening. Because we don't know if something has scared them in the past, if someone touched them from behind and something happened. And so we need to communicate all that.
And to help push your chair in right now. Is it okay if I set your bag right here? Like, communicating what you're doing, offering those choices.
I really appreciate you mentioning giving autonomy and safety as trauma sensitive response. I feel this is looked over a lot. And it really, in my experience, is very important. Thank you for all your information. All right. Well, thank you all for coming. Unless we have any other questions. This is being recorded and we'll post it online. But stay cool, and we'll see you all next month.